morning, friends. We are going to have a cataract session, and which we like to have as much of interaction as possible with the audiences. And along with me, Dr. Sanjay Chatterjee, Dr. Ajay Gupta, Dr. B.N. Gupta are with me on the chair, and the is Dr. Jay Gopal Agarwal here. So I'll request him to please give a talk, Diagnostic Pulse and Biometry, IOL Power Calculation with Recent Paradigm of Artificial Intelligence. So I'll request the speaker and please switch on the timer, and I'll request the speaker to please do not exceed their time limit so that we can have some fruitful discussion. Otherwise, it becomes a very unpleasant duty for us to really ask them to close your talk.
Time allotted is 7 minutes for each talk. Please.
Yes. Respected chairpersons, my topic is diagnostic pulse in biometry and IOL power calculation with recent paradigm of artificial intelligence. Now there is a long journey on biometry from ultrasound to set source biometry. Three major factors determine the IOL power calculation are mainly following: corneal curvature measurement, that is keratometry, central topography, axial length measurement, estimation of the anterior chamber depth, personalized A constant, and prediction of effective lens position. Now, we should not use the contact biometry. We must use the non-contact biometry, the optical, immersion, ultrasound biometry, and V-scan biometry when necessary. Optical biometry gives the most accurate reading, most easy to get, easily available, and most accurately reproducible, so it is our first choice. I generally use the IOL Master 700, though there is no financial interest, but it gives telecentric keratometric measurement with anterior corneal surface and step source in OCT technology for the measurement of the posterior corneal surface. If combined, then it gives the total keratometry. This interface of the IOL Master 700, it gives the both anterior and posterior keratometric reading along with the total. Now, central topography is also important, and IOL Master 700 also gives the central topographic measurement. At least it gives some idea about the central topography. There is the importance of angle kappa, that is Chang varying chord. For IOL with diffractive rings such as trifocal, bifocal, multifocal, and some extended depth focal field IOL, we want to place the IOL in diffractive rings to be concentric with the center in the patient's visual axis, as well as the center of the pupil, as it influences the performance of the diffracted ring. Ideally, it gives the best visual performance and the best satisfaction for the patient. Angle kappa is an angle between the visual axis and the pupil center. Now, it is again this interface of the IOL Master 700 with Chang varying chord. Here in the yellow box, it is the reading is seen. It must be less than 0.6. Then you should go for the these multifocals or trifocal IOLs. There are many occasions there we cannot do the optical biometry, such as mature cataract, and there are many other situations. Here we use the immersion techniques as it is more accurate and no corneal decompression. But here is, again, the problem is that it not takes the measurement up to the retinal pigmentary epithelium. So it should be corrected. But now the recent IOL calculation formula for the accurate results are, we have taken the 5 formulas. Recent is one are Oleson, Kane, Barrett Universal 2 formula, Hill, Robertson, and Lada super formulas. For the Oleson formula is an accurate estimation of the physical position using the newly developed C constant. The C constant is thought of as a ratio by which the empty capsular bag will encapsulate the fixation and fixate the IOL following the in-bag implantation. Here it eliminates the expected lens position with K axial length and the W. But here it is important that expected lens position is not considered. So it is better than other regression formula. Now come to the Keynes formula. It is also incorporates the artificial intelligence with theoretical optics. Here three parameters are considered: axial length, K, and ACD. Here again, the expected lens position is not considered, so it is better than other. In one study, it is shown that it is better than the other formulas, Hill RBF, Barrett 2, and Olesen other. But it claims, but it should be, but needs large cohort study and validation. Now, as it is also come in the literature, but it needs more validation. Now come to the Barrett's universal. Barrett universal is a theoretical model I with changes principal planes among the variety of IOLs by means of lens factor. The estimation of expected lens position is there. So it is not so much accurate in some cases, that is a large axial length I. Now Hill RBF, it is artificial intelligence based formula. It is pattern recognition based artificial intelligence. It is purely data driven and free from the limitation of expected lens position and free from the limitation of inherent standard. So it is better than other regression formulas. This is the interface of the Hill RBF formula. Now come to the LADAS super formula, how it works. LADAS super formula is based on the creating LADAS super surface. It includes 4 formulas, that is Hoffer Q, Holiday 1, Holiday 2 with Wang caution axial length adjustment, and Haggis, but not Barrett formula is considered here. But first picture shows that the each sweet spots of each formula and based on the axial length. And second picture is it is all connected. And lastly, it is all amalgamated. So gets the LADAS super surfaces. It is the interface of the LADAS super formulas. As soon as we enter the data in this formula, we get the result immediately along with the 3-dimensional graph. So the surgeon knows instantly if he is handling the typical or unusual eyes. If you compare the LADAS super formula with the Barrett's universal formula, here there are red marks area where it is not, they are not in the, equal power calculation. But here again, the LADAS super formula is better. And in the Barrett universal formula, there is slight difference after expected position. So LADAS super formula is the best possible calculation of eye power for all types of eye, extreme eyes, thus edge over the Barrett universal formula. Now, for the regression formula, which formula we should use, whether it is multiple, with different formula depend upon the anatomical consideration. This is very aptly described in the accuracy of IOL power lens calculation in the American Academy of IOL journals. Which formula is more accurate in all eye range of the axial length? Here it is shown that Barrett and the Olesen are better than the other formulas. Which formula is more accurate in all range of IOL power? Here again, the Barrett on the that is Haggis and other Olesen formulas are better than other formulas. Which formula is the more accurate in eyes with all range of anterior chamber values and with all range of anterior chamber depth? Here again, the Hoffer Q and Haggis and the Barrett are better than other formulas. And what is the effect of one cause optimization? Here again, the Barrett and Olesen are better than other formulas. Now, there recently another study by the Chang et al. The studies came in the Journal of Refractive Surgery in 2020. Here again, the Keynes, Olesen, better, or Barrett and the EVO are better than the other formulas. Now, how to decide the IOL power in the patient with post-refractive age? Here again, the ASCRS calculator. 1 minute only. ASCRS calculator is better and it is very easily available. Now, if it is silicon oil field, then again the optical coherent biometry is better than the ultrasound biometry because as the biometry gives the overestimation of the axial length. Now to conclude, the perfect biometry is at utmost important, that is swept source biometry instrument of choice, and the better to take the reading in the dioptric power in plus notation, it is important that incisional management of the astigmatism using the coupling effect. It is important to use a newer formula like Barrett, EVO, Oleson, Keynes, and Hill RBF, and Leda Super. Formula should be free from the limitation of expected lens position. Barrett universal 2 and Barrett to KT universal 2 is the most popular and accepted formula, though here the calculation of expected lens position is inbuilt and accurate, more accurate than other regression formulas. Hill RBF, Leda Super and Kane are artificial based and gives a very accurate result and constantly improving over time. Still we are improving and to get the best formula. Thank you. Thank you for the kind introduction.
Thank you, sir, for wonderful complete presentation of the biometry. I like to give just one suggestion to all of us is that you decide the type of the lens you are going to use. Suppose you are using the Alcon or Technis or whatever is the lens. And then the optical biometer gives you the reading of all 5, 6, 7 formulas of that particular lens. And then whatever formula is giving you the maximum power needed for the first minus, that means whether it is a Hill RBF, whether it's a Barrett, whether it's a SRKT, a Holiday, a Kane, anything. So whatever is giving you the more power, use that, because erring on the slightly minus side is absolutely no problem. But erring on the plus side will have a disadvantage. So I use the maximum plus. And with the coming time when people are more into the mobile users, they are, if it is say minus 0.5, they are usually very happy. So in the first eye, you can still use the second minus within minus 0.5. That means if suppose first reading is, first 22 is giving minus 1, then 22.5 will give you minus 0.43, 0.33 for each half diopter. So I'll now in this case, I will use the second minus for the first eye. Because if the patient becomes slightly myopic, I'm okay with it. And if the patient needs more vision for distance in the second eye, I will adjust it. So either the first minus, but of course this will vary in cases where you are using a multifocal IOL. So when you are using a high power multifocal IOL, that means synergy IOL, which has got a reading distance of say 33 centimeter, we do not want these patients to become myopic. Because if they become myopic, the reading distance will become 20 centimeter, 25 centimeter, which may be very, very uncomfortable. But if they are slightly hyperopic, it is okay if they read at 40 centimeter. And their size of the halos and glare also becomes larger if they are myopic. So if you are using the multifocal IOL, which give a good vision at 33 centimeter, then either emmetropic or the first hyperopic you should use instead of using the myopic. But if you are using the monofocal like Eyhance lenses, or if you are using a pure monofocal, if you are using a EDOF lenses, which has got only intermediate vision like Symphony, Vivity, then you can go for the first minus if it is more than 0.33, or second minus which is more than 0.33. So below minus 0.5 and around minus 0.3, minus 4. So with this, I'll now invite Mr. Vatopal is here.
Yes.
Thank you, sir.
So Rexis run out, then what? And I will request you to please stick to the...
Yeah, I'll try. Yeah. So, good morning, everyone, and thank you for giving me this opportunity to speak on Rexis runout and then what. So, we all know that complete Rexis is a prerequisite for good phaco, a perfectly sized Rexis and position CCC for premium IOLs is a requisite, and Rexis runout happens in 0.8 to 5.5% of cases, and Moorfield study shows the incidence of 1.55. So, in experienced hand, it can run out, but most commonly it runs out in intumations cataract. But in experienced hands, because of brushing and lack of concentration is another factor which we have to keep in mind, and other causes are pseudo exfoliation and pediatric cataract. So, prevention is better than cure. So, as I have said, intumations cataract is the most common type where it runs out. So, there are certain things which you have to keep in mind, such as staining the capsule with trypan blue, flattening the capsule with good cohesive OVD, and decompressing the central intralenticular pressure by a needle, as I will be showing in this video what I am doing. After OVD, I am going in, and at the same time, just before puncturing, I am aspirating as well, so that the intralenticular pressure is decompensated. And you can see the rhexis is going in a different direction, but it will not run out. But then I'll do a small rhexis. Why a small rhexis? Because in the middle, in the periphery, the pockets are not broken yet. So if I try to do a big rhexis, it can go out. So I'm doing a small rhexis. Now I will go in and break the pockets in the periphery. So this is important. There are different techniques. This is the techniques which works better in my hand. That's why I'm sharing this. Once this is broken, I go in with a venous scissor. I give an oblique cut. Make sure the cut is oblique and not perpendicular to the rhexis, because then again it can run out. And then I can extend the rhexis according to my choice. So this is how we prevent. Now if it goes out, so it's not a light, if you can put the light down please. Now you can see the rhexis is going out there. It has gone out there. What to do? So best thing, put in OVD. The OVD should be put where the rhexis is running out. Increase the magnification, and you have to flatten the rhexis. You have to put the rhexis back. The everted flap has to be put back, and then you have to pull it in and try your luck. So here I am putting the flap back again and pulling a quick jerk, pulling it to the center, and the rhexis is rescued. The next slide also shows the same thing. Here I was probably a bit casual. Everything was going on, and then it extended there at about 3 o'clock position, it extended. So again, the same principle follows. So you go in, put more visco where the rhexis was running out, flatten the capsule there, and then pull the rhexis in. So I have flattened the capsule, going with the forceps there, and a quick jerk to the center, and that is rescued. So that's how we rescue a run-out rhexis. Now you have to be vigilant as well. Here everything was going fine. I was about to come out, and the rhexis forceps got stuck with the capsule, and the capsule pulled out. Now I thought, okay, I was vertical, so it might not go out, and I was right. So what I did, instead of panicking that the rhexis has run out, I put whatever was out, I tried to put it back, and basically because it was vertically I was holding it, the iris actually prevented the rhexis to run out completely, and I managed to rescue it. So you have to be vigilant as well. Now if it runs out, what next? So it depends on the surgical expertise, grade of the nucleus, comorbidity, then you have to decide whether to do it in bag phaco or iris plane phaco, and about the iris IOL placement as well. So these are the few things which you decide. Now in this case, what went wrong? Let's see. So on the left hand side, I have enumerated the principles of following, but here the first steps went wrong. The staining was not good. What I should have done, I was a bit callous. I should have gone in and stained it again. But instead of doing that, I tried to do the rhexis. It was going on fine. I have done the decompensation. I am doing the rhexis, but then because of lack of staining, it went out. And I realized that when it went out, it has gone out at 2 o'clock. And because it is close to the sub incision thing, I couldn't rescue it back. So there are several ways of managing this stage. Once you can go in from the other side and bring the rhexis in there, or you can cut with the venous scissor and complete whatever rhexis is there, but you have to remember your capsule is open there, your bag is open there. So principle you have to follow here is minimal lateral separation, working away from the tear. Here the tear was at 2 o'clock. Try to maintain the anterior chamber as much as possible, and look for Rohit Amparkar sign. Sorry for the mistake in the name spelling. And if the flap is, if the extension flap is fluttering, then you are sure that it is not gone as a wrap-around tear. But if it is taut, then you have to be cautious, and you have to move to plan B, either ECC or anterior planar phaco or SICS in those situations. So if the flap becomes taut, that means it is becoming a wraparound tear. And you can see how slowly I am progressing. I am chopping very slowly, trying to do the phaco slowly so that the chamber is maintained well and so that the extension, it's not going beyond the extension. So for the lack of time, I'll move to the next slide, but you can see the principle is to do slow phaco as much as possible, work away from the tear. And here again, it was a straightforward case. No staining was required, but I lost the capsule again, probably because I was not using the right OVD, because I was using HPMC, which was leaking from the anterior chamber, and I lost the flap. So again, in this situation, I tried to rescue it, but I couldn't. And what next? I tried, because you can see my pool was not right. It was not towards the center. This is helps when you audit, re-audit and go back to your video. My pool was not right. It was not towards the center. So what I did, I made a nick on the capsule and rescued the rhexis from the other side. Just few seconds, one more slide, give me few seconds more. So I rescued the slide from this side to complete the rhexis. And then I had to nick again to enlarge the rhexis on the other side so that I get good access to the nucleus and carry on with the phaco as required. Just few seconds more, one more slide.
All of us have faced this type of problem. I think two things are important to
Just
prevent.
few more seconds, yeah. So this is another rhexis. Again, I didn't use the right OVD. It extended here, and again I had to do the same technique of rescuing. Because of lack of time, I'll skip this. And sometimes it shouldn't happen nowadays. Argentine flag sign. If you are decompressing the capsule well, you shouldn't have. But this is an old video where I had this Argentine flap sign. Here, again, you have to have a good access to the nucleus. So you nick the capsule, get a hemirhexis done, and then you nick the capsule again on the lower side, on the upper side, and get the hemirhexis down. Fortunately, these type of cataracts are quite easy to chop. So it's most of the cases, if not all, you can go ahead and do the phaco and complete the phaco. But again, the principle has to be followed. You have to keep sure it's not extending by looking at the flap sign. Do slow phaco and try, if you have 3-piece lens, give it on the sulcus. Otherwise, the option is giving single-piece lens on the preserved hemirhexis. Thank you so much for your patience hearing.
Yes, Dr. Chatterjee.
All of us have faced this type of problem. But I think proper staining of the capsule and adequate viscoelastic will prevent this type of complications.
Yeah, I think, yeah, Dr. Pal has nicely covered, I think, the situation which we can face in these kind of cases. So the main thing is that most of the time it's the sub-incisional area where once we reach in that area, that's the time when the rhexis tend to extend because OVD gets leaked out and chamber becomes shallow. So one should always have micro forceps in your armamentarium. So once you reach in that area, you should be careful. Again, put OVD, go from side port, and you can very well manage the rhexis. And I also do the same sequential 2-stage rhexis. I showed in 2011 ESCRS, and I've been teaching for years the same technique which you have showed. And I make a very small 1.5 millimeter. Try to make as small as possible.
The difference is probably you don't
Decompress.
Decompress.
I
because
decompress.
with the incision itself, it can run out. Even if you're planning a small rhexis, I have seen Dr. Pradeep Mahanto doing that. And instead of the small rhexis you are attempting, because of the interleuker fluid, before you complete the small rhexis, it can run out. So
No, it doesn't run out. It doesn't run out. I have hundreds of videos and it works very well. I do with micro forceps. And once you have the small rhexis, you can decompress, and it's important to decompress from all the ports. Not only from main incision, go from side port because you need to decompress as much as possible. So
I think the very valid point that we should make a small rhexis as possible and then try to extend it and try to decompress, which is well known. Just I would like to add 2 or 3 more points. One is do not over compress the chamber because the lenticular pressure is not going to go down if you over inflate the chamber. So most of the time we have a tendency because we fear that the rexus may run out, we put a lot of viscoelastic inside the eye. So intumescent cataract do not overinflate the chamber. Two, you need to differentiate between a curvilinear, it is not going to go to the posterior capsule. So if it is a curvilinear extension, there is nothing much to be worried about as compared to the radial cut. And of course, already highlighted that it has to be hypovolumic and never ever allow the chamber to collapse. That means when you are removing your phaco probe, going to change to the IA, you should put on a viscoelastic from the side port. So do not allow the chamber to collapse. When the chamber collapses, the vitreous will come forward and excess may run out. With
And
this, thank you.
one more last point, that the maneuver which he showed is very, very important, of pulling. Everyone should learn that maneuver, Brian Little's, no?
Yeah.
Pulling it.
Yeah.
So that is very nice. It's very useful. The moment you see it going outwards, stop, put OVD there as he showed, pull it. It will come back on track.
And thank you, sir, for this very valuable curvilinear extension. Yes, because that is important to remember as well. Thank you for the opportunity.
So now we'll invite the next speaker.
I think she's not here, she's doing some other session, Dr. Suchita. So we'll go to the next speaker, Dr. AIOCMTC1.
And please, the next speaker, keep your laptop ready onto the next slide. Next is Dr. Deva Prasad Gopal. So please, you can set up your. So Abhishek Anand,
So while he's setting up, sir, as Dr. Sugato mentioned about the fluttering sign, no? But I've observed that that can only be seen once the nucleus is out, no? So once we have extension, so key is to maintain closed chamber, because that time we can't see the movement of the flap. So that is the key. And once you have some of the nuclear pieces come out, then only we can see whether it's fluttering or it is. Yeah.
If it is not stained and if you are trying to concentrate,
Yeah.
then you can cause
Yeah, yeah.
so the
So-
chances of rexus going to the posterior capsule are very, very remote.
Yes.
Because I feel that it is always the prolapse of the vitreous forward which will make the
Yes,
rexus go back. So if it is a pressure from the top, chamber depth is maintained,
Yes.
rexus will not run away. And he is very right. So whenever you try to do, there is no need to do any supracapsular. In fact, keep the back filled. The rexus will not run away. Bring the things up, there are more chances of rexus running out.
So may I proceed with first of all, thank you to All India Ophthalmic Society for giving me opportunity. Today I would be speaking on management options in subluxated cataract through hooks and rings. Now, whenever we encounter a case of subluxated cataract, there are two ways which you can do. One, you can go for an ICC and lensectomy with SFIL, which is primarily a domain of a VR surgeon, or you can go for a capsular salvage with CTR and CTS segments, augmenting your outcome. I will be today primarily speaking on capsular salvage with CTR and CTS. Now, the pros of doing ICC lensectomy with SFIL is it has a shorter learning curve. It can be very well tolerated in borderline corneal endothelium counts, less chances of suture erosion or lens late subluxation with advent of sutureless SFIL, and suitable in progressive jonulopathies. However, the cons are that it has pigment dispersion and associated risk of high IOP, late pigment deposition over IL surfaces, floaters, ocular surface disorder because you need to dissect the conjunctiva, and posterior segment complications are associated. Now, if you are planned for a capsular salvage with CTR and CTS, you maintain the conjunctival integrity and it is almost not breached. OSD is avoided virtually sutureless. Capsular rim encasing the IOL, avoiding the pigment dispersion. Anti-hyaloid face integrity is almost maintained. In cases not amenable to lensectomy, then ICC is the only and associated complications can be avoided. Certainly, it has a long learning curve. Anterior chamber trauma is more. Incidence of tenoprolene suture erosion and late decentration of IOLs in comparison to a sutureless SFIL. Always needed to have a SFIL option as a backup because you never know when the surgery can, and it cannot be done in progressive jonulopathies. So let's see management options of subluxation with few videos. Now, the first and foremost importance is how you do a capsular exit, because once you mess up with this step, the whole step is gone. Now, whenever you are staining with trypan blue, you have to use the minimal, because if you stain too much, then this trypan blue can migrate through the deficient zonules and go back, and then you have the loss of the red reflex, and that alters your whole surgery. Once you have stained it, go for, as we have discussed previously, start with a smaller axis, and once you initiate, you should have all the armamentary in your bag. You should have a capsular forceps, whether you want, and once you are around your sub-incisional plane, you again augment your visco, and as we can see that the areas in which there is a jonular integrity, we can very well do the capsular access. But once you come in the area of where the generals are lacking, there is where you want to be very careful. Once we have crossed that area and we are sure that we have attained, and once you feel that okay, we have a certain, then you can extend it and do again double rexes. You can extend it, and what we achieve is a good centralized. Now we also have to remember that when you are doing a rexes, is that these are decentered. So you have to think in your mind that in the end you want a centered rexes once you put the capsular hooks. Now the other option, once you have done an access, is to put a capsular hook. Remember that capsular hooks have a different morphology than an iris hook, so I would not advise using an iris hook as a replacement of a capsular hook. My usual plan is for every degree of subluxation, I would use around 60 degree, I would use one capsular hook. So in this is more than 180 degree, I would use minimum of 3 capsular hooks. We don't need to over tent it. It's basically to support it and not to tent it, because if you tent it, then there might be chances of capsular tear and radial extension. You titrate the tension according to the number of hooks put and not in single hook that you put. Once you have put 2 hooks, you'd see how much is the tension, and the tip of the hook should go at the equatorial plane of the lens, and then you titrate the tension, and once you feel that you have got a sufficient support, you can go along with. Now the third most step is the management is you to put a CTR. Now this putting a CTR is, I generally put after doing the extraction of the nucleus. And what technique I use is I use a double handshake technique, in which I use 2 McPherson or suture tying forceps, and I keep changing the handshake technique, in which you just put the advancing edge and keep putting it. And at the end, when you have to put the last end of the cap CTR, you use iris hook to put it, and then you just depress it at the level of the capsular plane, because once the capsular tension ring goes in the sulcus, it's very difficult to retrieve it back. You again, once after you have put the CTR, you can stain the anterior vitreous and complete your anterior vitrectomy and remove it. Now let's see an option of a complete case. This is a case that was done around a few years back, and I would like to apologize for the poor quality of the video in this. But what we want to emphasize is this is a 45-year-old female, and who has more than 180 degree of subluxation. And what is important in this case is that once we enter, you would see that due to the posterior back pressure, the capsule, the lens is almost touching it, and we even wanted to repose it back, to push the lens back. I think in this case, a pre-operative injection of mannitol would have certainly dehydrated the vitreous and would have given us a better in the start. Once we have completed the staining of the capsule, we start with raising the flap of the capsule. And as we move forward, we feel that at this point, there is a capsular runout. But to our, it's more of our luck that it was not run out, and we could achieve a good centered, well-centered rexis. We again proceed with the next step of putting around to 60-degree rule that I follow, and around 3 capsular hooks. And once we have been able to put the 3 capsular hooks, here actually at this point of time, what you can do is that instead of putting a capsular hook, you can use a CTS, and you can use the CTS to insert it and put it on a tension mode. But somehow with the disproportionate size, we are not able to achieve it. And so we had to abandon this process. But this is also a very effective process in which you can put the CTS and you hook it with an iris hook. So we abandoned that process and we put another capsular hook, and we again proceeded with the, time is hydrodelineation, and we completed it. The all wrote that we have to be slow and gentle, and all the maneuvers and all the parameters has to be slowed down, and we were able to achieve the complete removal of the nucleus. And once we have done that, we proceed with fixing the CTS using a 10-O-proline sutures and making a Hoffman pocket. Now what we use is the new device Hoffman pockets, in which you enter through at the limbal incision, and you made a pocket, and then once you have dissected in the 2 mm of the scleral plane, you pass it by using the railroad technique. And once you have passed the tenoproline through the railroad technique, you retrieve the tenoproline from the groove. And since it's from the limbus towards the sclera, it's virtually you have not dissected the conjunctiva, and it's a complete integrity of the conjunctiva. Once you have done with it, you can proceed with implanting IOL. In this case, we implanted a single piece IOL, and we completed the surgery. Just one. To conclude, if attempting capsular salvage, attempt with SFIL as a backup. Due to deficient John Lewis vitreous hydration appears way quicker than anticipated. Use BSS judiciously. Pre-op mannitol can give you an extra window of time. Plug the jonular deficit with viscodispersives. Newer generation sutures like Gore-Tex or Fiber-Pro-Leaves virtually eliminate suture-related complications. Avoid capsular salvage in progressive generopathies and borderline corneal endothelial count. Coexisting pupillary pathologies, glaucoma, and retinal pathology needs adaptation of approach or multidisciplinary approach. Assess pupillary aperture preoperatively and try to achieve physiologically pupillary aperture through pupilloplasty. And in the end, do what suits you the best. Thank you.
Thank you for a wonderful presentation. Dr. Ajay Gupta, you have any comments to make?
Actually, when we doing in subluxated lens,
Take mic.
so what the difference we get if we convert it to SICS or we continue with phaco?
In my hand, I think if you are operating in a subluxated cataract, I think phaco is the way to go. Once you make the incision and open the wound, you are very high chances that you might end up in doing an ICC. I think phaco is way safer than SICS. If you have a closed chamber, more closed chamber and stable chamber.
So another point I would like to highlight over here, you need to find out whether it's a subluxation. Are there some genular fibers left over there? If you see the side of subluxation and you see the periphery of the lens little crenated, not as round as usually, that means there are some genular fibers are attached. So if there are certain genular fibers are attached, you are sure that the vitreous is not there. If you can see some of the fibers, if you see the crenated margin of the equator of the lens. But if the genular fibers are totally not there, and if it is not a congenital type of a subluxation, it's a traumatic, then you got to be very, very careful whether the vitreous is there or not. And so if the vitreous is present, then of course you need to do vitrectomy, limited vitrectomy, before you proceed for phacoemulsification. Because if by any chance you pull the vitreous, that would be very, very disastrous.
Can I add? Yeah. So very nice presentation, Dr. Abhishek. I think it is just like textbook that what should be done ideally. Very nicely you have shown all the steps. There are 2-3 points I'd like to highlight. First is, of course, the moment you make an incision and go in, first thing is to put viscodispersive OVD in the area where zonules are deficient. That will prevent any, vitreous herniation or whatever it is. Second, try to use very little of trypan blue.
Yeah.
Just paint it
Yes.
under OVD, whatever, because that can percolate through this and may cause problem with visualization.
Yes.
That's very important. And thirdly is, as you said, you should try to center axis on the lens and take care that where the area of subluxation is there, where you need to put capsular hooks, you always have a rim which is 1.52 millimeters adequate to hold the, capsular hooks. Thank you.
So we go to the next speaker.
Thank you, sir.
Dr. Devendra Prasad Gopal. He'll be talking about the management of all grades of cataracts by topical MS-ICS from plant faculty.
Is Sucheta back from the other session? No?
Dr. Abhishek, did you fix the back to the sclera in the first case? We didn't see that. In first case? CTS, yeah. So yeah, do you anytime use only CTR or CTR plus CTS? Yeah. It's I think easier.
Dr. Abhishek, in my one case, it was subluxated due to trauma. I was unable to do Rexis because whenever I was putting the needle, the lens go back. So then it was the very difficult situation. So what you suggest for that?
No, I'll suggest you whenever the lens is going down, use two needles and use the counter pressure
Cross sword
puncher.
technique, yeah.
So go from the two sides, one needle from this side and another needle from that side, and just go bang opposite to each other.
And
Because when you are trying to push with the one needle, you are pushing down, but when the two needles are there, you just go.
And another trick is I have Artley machine, no financial interest. It has radio frequency capsulotomy probe. So in a cases like microspherophakia and subluxate where it's difficult to puncture, I just go ahead with that and it gives a puncture. Once you have puncture, you can cut with micro scissors and enlarge it. No, I also don't have flex, but what I know is in extreme of subluxation where the lens is decentered, it doesn't work. That's what I'm aware of. Maybe Dr. Vanshal.
I think I don't have flax, but at the same time, the only thing is once, as I told you that do the rexes by two counter pressure, and once you have got some lift over there, some puncture is there, after just 1 or 2 millimeter of a rexis being done, you can keep the one end lifted with the rounded depositor up. You can place the hook. You don't have to place the hook when the rexis is complete. You can place a hook beforehand, but do not give it pressure, do not try to pull it, just to bring it up. So you can place a hook. Normally I use a rounded depositor from the another end, so I keep slightly lifted up so it's not going down and do the forceps rexis. So I am able to manage with that, with the counter pressure and trying to keep the rexis lifted up with the second instrument while I'm doing the rexis.
Yeah.
Yeah, you can hold with the forceps. I use the rounded depositor to lift it up.
In the meantime, Dr. Sucheta, you be ready on the next podium.
Yeah, thanks for the opportunity. I would like to present today cataract surgery. All these cases basically were planned for a phaco emulsification with a moldable iolic implantation, but later converted because of the difficulty. So initially, first case which I'm going to show you is an intumescent cataract. So I did a routine staining of the anterior capsule with triband blue dye, washed it, and then injected copious amount of viscoelastics. And I was expecting a little problem in rexis, but as I predicted, the rexis started extending and the tear extended to the periphery. So I immediately converted. That is the advantage of doing the rexis from the side port before the main incision. So it helps you to easily convert into a sclerocorneal incision. Then a 6 millimeter scleral incision was made, and then we went ahead with a sclerocorneal intervention. So So sclerocorneal tunnel is made into ensuring that it is of the partial thickness and then make a proper and adequate side pocket, which is very important to lodge the big nuclear cataractus lens. So once that is done, we enter the anterior chamber with the keratome. Keratome goes inside and cuts while going inside, and then once it is done, I just remove the nucleus by sandwich method, and then the cortical aspiration is done, and the IO allied, I intend to put a rigid IO because of the extension of the rexus margin. So first the leading aptic goes inside, and next the trailing aptic is tied inside into the bag. So though the case was little complicated and rexus extended, SICS saved the day for me, and I could place the lens in the bag with a good outcome from the first post-operative. So this is my first case, and many a times in intumescent cataracts, your SICS will come to your rescue, and that will save you from making any future complications. So going ahead with the second case in this scenario. Second case is also a dense cataract, which was initially planned for a phaco and foldable IOL implantation. I thought initially that this is a type of intumescent cataract and I can easily do a phaco. I just started my initial steps, put a side port, then stained the anterior capsule with the trypan blue dye, then washed the dye, and then I injected viscoelastics. So while doing rexus, because of the previous case, I thought I should not put a lot of pressure on the capsule. I thought I'll do my rexus little carefully. So I started the rexus by taking a central nick onto the anterior capsule with the cystitome, and then slowly started the rexus. I was very skeptical that it would tear, so I just went on. I slowly did my steps. I didn't fast forward it. I just slowly gave a nick by nick, and I started pulling the capsule, and it was all going on well, and because I was planning phaco, I thought I'll do a little 4.5 to 5 millimeter rexus. So I did the rexus, and it was quite centrally placed, and I was happy about it, but something told me that this can't be done, phaco cannot be done. I immediately converted it, but the challenge was to deliver the nucleus from the small capsular opening, but I could lift one pole of the nucleus outside the capsular bag, and then I slowly cartwheeled it into the anterior chamber. So once that was done, the entire nucleus came inside anterior chamber, and I could deliver the nucleus by the sandwich method. So this was a very hard cataract, which was not known in the beginning of the surgery. This is a hard brown cataract. Then I delivered it by the sandwich method, and then IOL was placed inside the bag. So these are many conditions where SICS will come to your rescue. So learning SICS in the initial phase before starting your phaco is very, very important and good for your surgical expertise. So after inserting the lens, then actually the results are quite as similar to the phaco, because you would have promised phaco and foldable lens to the patient, and you would have converted it, but it's easy to convince the patient because your recovery and your post-op vision is quite good. So in the same way, I would like to show you one more case in the same day. I thought after my rexus. So then the anterior capsule was stained, and then is little elastic in young patients, and if you are not able to get a good CCC, which is very much detrimental for your phaco, the rest of the steps becomes very difficult. So I went on with this thing. I had made up my mind that I'm going to do a phaco. I just went inside and I did a little smaller rexus as predicted, and I was quite successful in doing the rexus. So and then after removing the nucleus, then the cortical aspiration was done, and I could place a rigid lens inside the bag. So all these conditions which was posted for phaco, but I had converted it on table, and all these cases have been done under topical. There was no block given. I had planned for a topical phaco, but I ended up doing a topical SICS. So the take home message would be that SICS is not inferior to any other procedure. It definitely gives you better results, and it also saves you from future complications like PC tear or your nucleus drop if you attempt phacoemulsification in harder nucleus, smaller pupil, intermittent cataract, pseudo exfoliation, and all such conditions. And if there is any doubt that you can't proceed after your excess, I would advise you to just convert it into a small incision cataract surgery and give the best outcome to the patient, because what the patient is going to see is the first day first show, or when his eye patch is removed, how much vision is going to regain. So the result should be good. It doesn't depend which surgery or you are going to do. So this is my this thing, and if very small people have or any pseudo exfoliation or any zonular dialysis, or if it's an iris coloboma, I would advise you to block your glasses with a subtenance or a peribulbar block. Take adequate precautions and then go ahead with the case. And cortical aspiration and putting the lens inside the bag, and that's it. I would like to present on the bag. Hi friends, today I would like to
will not have any discussion now. So now I invite Dr. Sucheta Parija. So please stick to your time of 7 minutes.
A very good afternoon to you all. I'll be talking on pediatric cataract surgery step by step. I have no financial interest in this presentation. So pediatric cataract are a treatable cause of childhood blindness, and as we know, 41% of them are seen routinely when we do a routine examination. They can present to you with a different morphology. They can present to you with a jonular cataracts, lamellar cataracts, or they can be membranous cataracts or sutural cataracts. And unilateral cataracts are very important. You have to take care of trauma, uveitis, idiopathic, and also look for any ocular anomalies in these cases. What is important in bilateral cataracts, if you have, they are either familial or syndromic. And it's the unilateral cataract which you have to look for, because the pathology lies inside the eye. So the indications and surgical timings are very important. Pediatric cataract surgery is complex and challenging. The goal of surgery is to clear the visual axis. So timing is for unilateral cataract 4 to 6 weeks and 6 to 10 weeks for bilateral cataracts. Now the pediatric cataracts are different from the adult cataracts, and you have to take care of the axial length also growth which is there. Then the which IOL formulas, biometry, UA is very important in these cases, and instrumentation and GA, everything has to be taken care of. You should have high viscoelastics before you start your case. I'll be discussing on incision and the capsular management and about the anterior vitrectomy. So this is a 7-year-old boy who presented to us with a bilateral lamellar cataract. We went ahead to do a side port incision. You have to always stain the capsule for the, not only for visibility, but it makes the capsule soft, and you have a controlled manner. Use always a Atrata fusses of micro scissors and grass, press grass. Put high viscoelastic so that you get a adequate rhexis, which is very important. If you lose the rhexis, then most of your pediatric cataract you are losing. Do a hydrodissection, and the cortical matter is grumpy. You can do a bimanual, and be very careful, meticulously. You have to take all the cortical matter out. Do the anterior and posterior capsular polishing. Well, you can give in a hydrophobic in the bag IOL, which is a single piece IOL, and that fits very beautifully. Never forget to hydrate the wounds and put a suture in these cases. So anterior capsule management is very important because this capsule is thinner and stronger and more elastic than the adult. So you have to be precise in your surgical maneuver. You can use the Ken Estel's two technique, push and pull, where you give 2 incisions and then continue it. You can use a vitrorhexis, or gypto is coming where you can get a circular rhexis. Very femto they are saying, but it is difficult under GA to do these cases. Now managing the posterior capsule, that is very important. And after you have done adequate CCC, anterior CCC, you just do it with again 3 millimeter around a PPC in the cases, because that is very, very important. We don't want to have a PCO in these children, and you do a vitrectomy. Now you can also do in a different method. You can put in the intraocular lens, go about just hold the lens up, do the prick, do your capsulorhexis in these cases, and then you can use your forceps to complete the capsulorhexis, and then do a vitrectomy in these cases. But this technique is more difficult, but in some cases you can go about to doing. But main important thing is taking care of the PPC. So posterior capsulotomy with anterior vitrectomy is a must for children up to 6 years. After till up to 8 years, you can do a PPC in these cases without a anterior vitrectomy. Very important is this anterior vitreous phase, which acts as a scaffold for the proliferating lens cells, has to be taken care of so that the PCO doesn't occur. You can have intraoperative problems in form of intravitreal pressure and this wound leak. And this is another case which I'm showing you. Sometimes you usually have this traumatic cataracts along with it. And here if you see, the anterior capsule is mostly thrown in these cases. So we don't know whether there was any vitreous or not. So we went ahead, and what I was trying to do is, I was trying to do a rhexis just keeping underneath. So I have left this anterior capsule which is torn about and did a rhexis and a circular rhexis, so that once you get the rhexis clear enough, round enough as CCC, you can go about slowly, take out the cortical matter which is there, and what happens once you, and you can take the cortical matter out, be careful, and you can still put the IOL inside the bag in these cases. So, So IOL selection is always a controversial if it is 1 year, but the infant phakia study showed that within 4 years there was no difference between these two groups, whether you put a phakia and contact lens or you put a intraocular lens, but the repeated surgery was higher in the IOL if you have implanted IOL within 1 year. So taking care of the post-operative inflammation is very important, and PCO management. So problems are always there because ocular dynamics, it's a growing eye. Amblyopia therapy has to be taken care of, and multiple refraction has to be taken care of. So anterior capsulorhexis is the key for safe IOL implantation, and do not fear for anterior vitrectomy in children. In most of the cases, the IOL should be inside the bag and never leave the wounds without suture, because you may have difficulty and multiple times you cannot take the children for GA. So be prepared for all type of surprises, and it is just said that if you are dealing with a pediatric cataract, the journey has just begun. Thank you.
Thank you, Dr. Sucheta, for finishing on time. Now we have got the last speaker of the day, Dr. Sunil Kumar. He'll be talking about phacoemulsification in heart cataract, the right strategies.
So very good afternoon, everyone. So I will be presenting on the phacoemulsification of the heart cataract and what should be our right strategies. So I have no financial interest in any of this technique. So we many times faces with this hard brown cataract, and they have having the specific and difficult challenges. Like the poor red glow, so the rhexis might be difficult, so we need the staining. And hydro procedure is also very crucial in these cases because they know a space because of the very hard and bulky and large nucleus. Also, they are associated with leathery posterior plate, which sometimes fails to separate. There is no epinuclear plate of the cushion to protect the posterior capsule, and there can be associated with the poor pupillary dilatation and jonular instabilities. So pre-operative evaluation, so detailed slit lamp examination to know the exact grade of the cataracts, the AC depth, the pupillary dilatation, and any associated comorbidities we have to look for. And most importantly, we have to look for the status of the corneal endothelium. So what are the important intraoperative strategies we should follow? First is the staining of the anterior capsules and making the decent size of the capsular rhexis. At least we have to aim the 5.5 millimeter of rhexis. Use of the dispersive viscoelastic and soft shell techniques. And there can be the many techniques for the nuclear assembly, but my go-to technique is to make the central crater and do the direct chop, that is a vertical chop. And using the long sharp chopper definitely help in these cases, and the tip exposure should be more. And we should try to complete separation of the posterior plate and make multiple sub-chops. And generous use of the viscoelastic during the nucleus disassembly is very, very important. So I will show some videos. Sorry.
So after straining the capsule, we are trying to make at least 5.5 millimeter rhexis in this case. You can see this is definitely very, very hard cataract. And after straining the rhexis, we have to make the very gentle hydrodissections. And multiple quadrant, a small amount of the fluid we have to do. And this is the phaco. We make certain central crater in this case. Because this making the central crater definitely weaken the central core of the nucleus. And this is the direct job. And we should try to separate up to the minimum up to the center of this cataract. And multiple sub-chop is being done. And this is the small central endonucleus which is first emulsified. And we can make the further sub-chop whenever it is necessary. And we change from the sharp chopper to the blunt chopper when we try to eat each piece. And the very little cortex is there in these cases. So we do by manual irrigation, we just spread the cortex and implant the single piece IOL. Now this is the next case. This is the slightly a smaller pupil. And this was actually the case of the chronic glaucoma. So again, after staining the capsule, we have to try to make the 5.5 millimeter rhexis. And in all these cases, we should not hurry in making any of the steps. You can see again the hydrodissections and rotation of the nucleus is very important. And here just to make the central trench. And again the vertical chop. So in this vertical chop, definitely the high vacuum and high flow rate definitely helps. And the hold of the nucleus should be very good. And we should use the viscoelastic in between these cases also. I have not shown here re-injection of the viscoelastic for the time constraint, but definitely we should do at least 2 to 3 times during this nuclear disassembly. And we have to be very careful during the last phase removals. Again, we have left with very little cortex, which is removed with the biomanuals. And the single piece IOL is being implanted in the sulcus. And the visco should be removed from the anterior chamber as well as from the capsular bag. Yeah, I will show this last case. This is again the hard brown cataract. Again the same technique, making the two-side port, nice staining of the anterior capsule, and making the decent size of the capsule rhexis. We should to make the smaller rhexis. Again the hydrodissection with very small amount of the fluids. Make the large central crater in this case. And you can also see that the tip exposure should be more in these cases because the lens is very bulky. So when the tip exposure is more, we can hold the nucleus better. Again doing the multiple sub-chop. And removal of this central endonucleus is also important before trying to remove the chop. And so this the little cortex is being removed, and the single piece I will implanted, and the visco is removed from the anterior chamber as well as from the bag. So to conclude, the detailed preoperative evaluation, so how hard is the cataract, and if we are compatible with going with the phaco or not, it is the personal choice. And using the right strategy, phaco can be done safely even in the very hard brown cataract. So thank you very much.
Thank you for finishing on time. And I thank my co-panelists, Dr. Harshul Tak, Dr. Sanjay Chatterjee, Dr. Ajay Gupta, and Dr. B.N. Gupta. And now